Well, good morning to all of you, and again, welcome to Cardiovascular Innovations. It's a real pleasure to have you all here at this meeting. My presentation is going to focus on the commercial outcomes with MitraClip, and I'd like to talk about it a little bit in the light of what needs there might be with regards to the transcatheter mitral valve space. Here are my disclosures. So in this talk, there are several key points I'd like for you to keep in mind. First, when it comes to MitraClip, the acute procedural success is about 92% with an in-hospital mortality of about 2.7%. Despite what we do at about 1 year, mortality occurs in about 1/4 of the patients, and about 1/5 of these patients still are hospitalized for repeat heart failure. And then in terms of the outcomes, the factors that drive these 1-year outcomes are age, dialysis, lung disease, lower ejection fraction, severe TR, as well as residual mitral regurgitation. Well, as many of you know, MitraClip is a device that is a 24 French system that is deployed transeptally, and the idea is to oppose the anterior and posterior leaflets of the mitral valve to decrease mitral regurgitation. And thus far, over 50,000 patients have received this therapy worldwide, and it's been approved elsewhere in the world for a number of years, but in the U.S. it's been approved since 2013. Well, we analyzed the outcomes of the commercial experience and presented these at the American College of Cardiology earlier this year. And in this analysis, and Dr. Feldman was a co-author on this, there were about 3,000 patients who were treated. The median age was 82 years. The STS PROM for replacement was 9.2%, and the in-hospital mortality, importantly, was 2.7% in this high-risk population. The other important findings are the rate of LCDA, which was 1.5%, which is a lot lower than the preclinical experience, and also importantly, the length of stay was a short 2-day hospitalization. So here are the effects on MR with MitraClip, and what you can see here, and it's already been discussed earlier, you do get a significant reduction in the MR with 93% of the patients getting down to grade 2 and about 60% getting to grade 1 or less. So these are the numbers we often quote our patients, and that about 2/3 of the time you can get almost a surgical-like result, but more than 90% of the time you will get a significant reduction in the MR. So now using CMS-linked data, we then analyze the 1-year outcomes, and what you can see here is that despite what we do, again, about 1/4 of the patients still will die. And this is somewhat reminiscent of the partner data in the fact that these are patients who are high or prohibitive risk, and they have other morbidities that will drive their long-term outcomes. The rate of heart failure rehospitalization was 20%, 6% needed repeat clip procedures, and repeat surgery was 2%. Now, there are also other important insights with regard to the outcome of MitraClip in this commercial experience. And here are the 1-year death rates for patients segregated according to FMR versus DMR. And you can see here that the FMR patients had a higher rate of death. I don't think that's a surprise to anyone. But here, this is what was quite striking, is that at 1 year, the rate of death or heart failure rehospitalization occurred in almost 1/2 of the patients who had FMR. So as you look ahead at the results of COAP as well as MitraFrance and Matterhorn, as we're anticipating what those results might show, I think you can look at these data and surmise that we suspect there are plenty of endpoints for analysis. I don't think there will be a shortage of data points to look at to compare the two arms to determine whether or not MitraClip is effective if we're looking at death and heart failure rehospitalization. Another important insight is that when you look at these patients, the morbidities of what they have will drive their long-term outcomes. So here's the impact of TR. TR occurred in about 15 to 20% of patients who had MitraClip, and you can see here that the presence of severe TR for patients who are treated was an important 1-year outcome in terms of mortality. Here, 39% of patients who had severe TR died despite MitraClip therapy. So again, another important finding that will help us put into context how we choose our patients for MitraClip therapy, but it also has an implication for what other therapies that need to be developed. If we don't also treat TR and develop therapies that will help address that as well as a mitral regurgitation, we simply won't be addressing all of the patient's problems and improving their prognosis. Another important aspect of the study that was found was that severe MR, when incompletely treated, was associated with a worse outcome. So here you can see this is grade 3, 4 MR versus grade 2 versus grade 1 or none. And you can see here, not surprisingly, if they're left with grade 3 or 4 MR, which is essentially a failed procedure, about half of the patients were dead at 1 year. If you look at grade 2, however, there also was a slight penalty for having residual grade 2 versus grade 1 or no MR. So now certainly when you look at these data, these procedures are being done in patients who have no surgical option. They're meant to be prohibitive risk patients. So the operators are going to do what they can do to improve the MR reduction. And perhaps grade 2 is all that they can do for whatever patient they're treating. But what I think this shows you also, though, is that if you can get these patients to grade 1 or less with whatever device you use, whether it's MitraClip or something in the future, the patient probably will be better off than if they're left with grade 2, and certainly they'll be better off than if they have a failed procedure or with grade 3 or 4 MR. And this is just a multivariate model that shows you the predictors again: age, dialysis, lung disease, low EF, severe TR, but also residual MR was an important predictor. And I think when we start looking at these MitraClip patients, you can also think about how we look at our aortic patients. In the TAVR discussions, we often talk now about cohort C patients and whether or not to offer them transcatheter therapy. I think the discussion about that for MitraClip and other transcatheter therapies is just starting, and we'll have to better define who are those patients in whom we probably should not be treating with this therapy. So in conclusion, success rates are very high for the clip. Hospital mortality rates are low. Despite what we do, there is still a significant event rate for mortality as well as heart failure rehospitalization. And then we'll have to, think about what those drivers are in terms of prognosis, in terms of selecting our patients better for this therapy. So thank you very much.